for inviting me. Thank you, Abdullah. Thank you, Ibrahim. And I was asked that to wake you up after lunch. What, ما تحتاجي? Okay. And the other thing, there are prices for the questions to answer. And so, not every question there will be a prize with. I will tell you which question there is a prize for it. لا لا لأنه it is going to be real cases. لا ما أعرف جائزة عند محمد إبراهيم هو اللي بيعتبروا الجوائز. هو because it is real cases, but it will just that when we are seeing cases sometimes we have a differential diagnosis. فعشان كده. But let's start. Case number 1 is a complex case. He is post-allo bone marrow transplant. He has got graft-versus host disease. According to a lot of previous bad history, CMV bacteria, he's hepatitis B antibody positive. And he has got TB in 2020, diagnosed in India and treated. And it was confirmed TB. His chief complaint when he came was fever and pleuritic chest pain. And so it was in his usual health until 4 days, so it was an acute presentation. However, 2 months previously, he had COVID. He's from Yemen, school teacher from Yemen, no history of contact with animals. He went to India, as I mentioned, for TB and was treated for the TB. He attempted fluid because it looks like he had TB with the pleural effusion. He went to Egypt, I don't know why, but then he came running from Egypt to King Faisal Hospital. So, this is a question, there is no prize for it. Okay? So, which of the following is the most likely? Vote, please. Please vote. Stand and vote so that we can pass. We want to see how many, the percentage of each answer. Wow. Yeah, Rahim, is it going all right?
Yeah, it's good. So far, 6 votes.
Only 6 voted. It's have got graft-versus host disease. So the 12 answers. So for the sake of time, I think we will move on, and we see that we cannot agree, which is the usual of IDP. They never agree. Okay, this was his lab test, including the liver function test, and the abnormalities in the liver function test. Okay. So when we did the CT of the liver, we found that there is an abscess in the liver. And so, with the abscess in the liver, you can see the image that he has got the consolidation in the right side as well. This is the previous CT, which was about 1 month before his presentation. It was normal. So this was his previous microbiology, if you want to know what infection he had, and the previous control he was on. Next question. What is the most likely microbiological diagnosis? Huh? You feel close to it? Yes. Yes. Okay. By the way, from the blood. Got positive microbiology from the blood. Answer, which is better than before. No, Jim, class? Can we move? Yes. Okay. So it was flat and yeast. Right. Right? Whoever will answer, and he's the fastest to answer the right answer, you will get the prize.
Then we have to read the question in front of someone and they can. Yeah.
Yeah, okay. So the next question, few prizes, right? ما أعرف I don't know.
لا تستاهل تحية له برايس اكيد.
طيب, okay. Yeah, the next question. Which of the following is the most likely isolate? Was it Cryptococcus, Candida albicans, Candida auris, glabrata, Trachospora? How many answered? 16. والله متحسنين. Who was the fastest? Okay. Who said Cryptococcus? Win. So the one who said Cryptococcus is the winner. أنا ما أعرف. Yes.
العام الماضي فاز 3 مرات. ايش السر ما أعرف. تحية لمحمد.
So this is a question to the clinicians. And there is a prize. Be careful in choosing your answer. If the blood culture is positive for crypto, you would request a CT cap, do lumbar puncture, request blood cryptococcal antigen, request CSF cryptococcal antigen. Give her the prize. All right. Okay. And of course, this is because this is always a very common question that people forget. He was asymptomatic from CNS point of view, but the cryptococcal antigen in the CSF was. This is his CSF result. You see there is no WBCs with 2, because this is also supposed to be educational. Right? But his cryptococcal antigen was positive, and the cryptococcal antigen was more than 2,040. So it was very high. So, and the blood culture was called cryptococcal, the CSF culture were positive. So, in spite of being asymptomatic, in spite of the WBC, there was no the CSF, no WBCs, he had cryptococcal meningitis. So, this was a sensitivity, we will go ahead. He was treated, and so, what would you start? Answer. So they all said the first one, so no prize for this one. خلاص هي خلاص. Give her the prize. 93%. Excellent. Okay, and this is just the clinical guidelines about the treatment of this. This high. Yes.
If you isolate a yeast and you have consolidation and the liver, it will not be candida. Unless this is just two separated pathologies, no relation between them. And then Trichosporum is very close to candida in the way it presents. So you'll end up with the crypto, in fact. And whenever you get crypto, you have to do CSF. Crypto, as you know, crypto meningitis is an indolent disease. It creeps up over even weeks. So patient is not surprising that he is well, I would say, or not very sick.
The immune system reaction was created a disease. So in HIV patient, they have crypto and excursion from CSF. They are negative until they start antiretroviral therapy. So this patient is immunocompromised. It's unexpected that he may not manifest as with meningitis when you have a crypto, because antigen antibody reaction rather than the presence of the contact.
I wanted to ask because he's from Yemen, so we see patient with I think from Yemen.
Was it
Species?
yes?
And no, because I thought maybe it was. But you know, actually he's insisting that he got the crypto from King Faisal Hospital. Not in the hospital itself. He said that when he came to Riyadh, he was staying in a flat. And when he went to the flat and he's staying there, because he wasn't follow up, he was opening the window, and always, whenever he opened the window, he found the patients.
Because I've seen a patient with immune competent with cryptococcus meningitis and he lost his eye from, and when I reviewed the literature from Yemen and tropical countries, they have cryptococcus agati in immune competent individuals, actually, not immune compromised. And classical with the loss of involvement in the eye and the CNS involvement.
Okay. So, how many believe that you are dealing with crypto? With crypto. The whole. Okay, let's move. You have persistent right-sided abdominal pruritic and pruritic pain. What would you do next? Please vote. Repeat CT liver, and I would say repeat CT liver, and if there is any collection, aspirate. Yes. This is what was done. And so what will 5 cc of sick fluid was aspirated, and the microbiologist test you will request in this specimen. What will it be? Routine gram stain, TB, acid fast, or NDA? All of the above. Okay. If you said all of the above,
This is a precious sample, so you have to do everything from one card.
okay.
And for the exam, you can say whatever you want.
Thank you very much. Now, hi, you can comment. What is the usefulness of India ink in this process?
Typically, it's not that useful in non-CSAP. So I think pathology here would be good. If you do cytology, I think would be useful.
Right, okay. I think I agree that we have to send it for everything. Which one of this came back for?
AFB.
Lisa, thank you very much. That's good. So, this is what came back for. Beaded gram-positive rods were seen. So now there is a prize for this. There is a prize for this. Which of this is the most likely?
Asteroids.
Yes,
There is a new change in the classification of nocardia.
okay.
Recently, nocardia, steroids have been divided into multiple, including Farxinica and the rest. I don't remember all of them. But there's a large list now, they divide them into types 1, 2, 3, 4, 5, and 6. And as nocardia, steroids has become like a big known thing. So currently, we don't see steroids as like a standing species alone. So it's there are multiple species under one nocardia.
So Mustafa, which one did you vote for?
Both, if you follow the old nomenclature, it's either steroids or Farxinica. Either one of these, not abscesses.
So you do not have one. Who said Barcelona? Give him the prize. Yes, Muhammad. You are right. And so actually, it is a very difficult case. We really need sensitivities, so we did the sensitivities. And this is the sensitivities. I'm not going to bother you with the treatment. The treatment was so complex because of adverse drug reactions. We gave him combinations of therapy. At the end, he ended with being given imipenem, convenous amikacin, and linezolid. And then he actually took tetracycline at the end. Okay? Now, his right side abdominal pain resolved. Repeated ultrasound showed improvement, interval decrease in the size, and then he had a new image, and there is a new infiltrate in his lung.
This is why he isn't taking.
Oh, yes.
What is his immune status?
It's severely immunocompromised, and you can tell even if we don't do
What
it.
is he getting now for his GVHD, right?
Yes, he's on multiple courses of immunosuppression. So the new findings is called keeping with an infectious process. So, this is the bronchoalveolar lavage. So what do you think the bronchoalveolar lavage confirms? Is it pneumocystis, TB, crypto, nocardia, or aspergillus? So now we have got two. We have got the crypto, and we have got Yes, he had a CMV, but it is not CMV. Actually, 15 votes. I don't know who got the right answer. The right answer is there. Actually, 56%, half of you got it right. It was Aspergillus flavus, and his galactoman in the bronchial gorilla was 8.
I was one of the
He is the one.
right answers. Because I think he might have acquired, hospital acquired.
Yalla Ibrahim, let's move to the next case.
Thank you.
Another case. Yes. Crypto and Aspergillus was isolated but both of them. This is crypto.
It's not contamination.
What about the galactoman and B8? Hi, does crypto give you a false positive galactoman?
Actually, beta glucan غير موجود.
Galactoman
Galactomannan should be there.
should be there. So I think we agree. Okay, case number 2. He's a 36-year-old.
CMV is good for aspergillus. It adds to the lighting.
He is an end-stage renal disease, urogenic bladder, cadaveric, and he has got a fistula because he lost his blood. He presented to the emergency room with fever, nausea, vomiting, and diarrhea for 2 days. Actually, he started with very high fever of 39, with chills and rigors. The following day, it started with diarrhea. Headache and decreased urine frequency. He did not eat outside. All his history, trust me, was negative. He could not add anything else in his systemic history. This is his medication. He's still taking tacrolimus, mycophenolate, prednisone, furosemide, calcium, vitamin D, sodium. He's not known to be allergic. He received 3 doses of coke. Past medical history, as I mentioned, he has got fistula created. He had recurrent UTI. He was on Cipro for prophylaxis until 1 month back. He's single, living in Riyadh, works in the Ministry of Interior. No farms or animals around him. Denied milk ingestion or recent troubles. He's a non-smoker. Physical exam was very highly febrile and tachycardic, but he was maintaining his blood pressure. Otherwise, only tenderness over the graft, nothing else. This is his blood test. He's severely acidotic, bicarbonate of 9, and he also is hypocalcemic. Okay? This is his chest X-ray. Ultrasound did not show anything. So, as I mentioned, severe fever followed by diarrhea, and severe renal dysfunction after that. This was our impression. Could it be gastroenteritis? Could it be C. diff? It was on Cipro. Could it be CMV? Bloodstream need to be ruled out. Possible complicated UTI. So we were nowhere to know exactly what is the source of his presentation. He was started on meropenem and vancomycin. He was admitted. Dialysis was initiated. 2 days later, his fever subsided. Symptoms improved. Septic well cup came back negative, and his C. diff was negative. 3 days later, the patient developed peroral numbness and slurred speech. His power was 5 out of 5 in all limbs. No signs, no focal signs otherwise. His calcium was extremely low. So he was started on calcium, symptoms started to improve. This is his ECG showing prolonged QT. And on the 4th day, the primary nurse called because the patient had left upper limb weakness. He was complaining of slurred speech. No intervention was done because of that, actually. So, neurology were called. The stroke team were contacted. Stroke was activated. They came and they said, there is no stroke. Okay? So, electrolytes started to normalize. Cardiac enzyme was insignificant. Echo did not show any mutations. 12 hours later, he became quadriplegic. Eyes were normal, no extraocular movements were all normal. He had left facial weakness. Bladders were mute bilateral. The the reflexes were crisp. So, what is the most likely pathogenesis for this neurological syndrome, post-gastroenteritis in our case? What are the indications?
Scan the QR, please.
So do you think this is a vascular, metabolic, is it inflammatory, is it infectious, or is it drug induced? There is no prize for this one. Why there is no prize? Because honestly, the five are right. Because this is just the pathogenesis of this. It could be any of this. So anyone who answers any of this is right. No, لا vascular, but it must go. So I'm just going, what are the infectious things? So hemolytic uremic syndrome, you were talking about E. coli 157. Toxin related, could it be botulism? Shigella is used. Okay. Now, okay, demyelinating, people talk about Campylobacter. There is something known as axiophthalmoplegia. Elam, also acute motor axonal neuropathy. Okay, also we saw that could it be listeria, could it be enteroviruses, could it be Campylobacter, and then of course drugs could be related. So, neurology came, MRI brain done, metabolic uremic encephalopathy, true? No. Hypoxic ischemic encephalopathy, which I don't know what do they mean by that. Anyway, lumbar puncture was planned. This was his CS. Okay, ready? Hello? You made your diagnosis? Now you have to vote. So, lymphocytic meningoencephalitis post-renal transplant. This is a simple question. There is no prize because could it be enterovirus? Could it be listeria? TB? Could it be post-TSD? Or it could be another bacteria. So to be honest, no prize because any one of this would be right. But I wanted to see how did you look into it. So you feel that it is viral. Some people say it's TB. Some people say it is listeria. Listeria would have been dead. He would have been dead. I think someone is going to talk about it today. Yes. So, a multidisciplinary team, we were sitting, but in the meantime, while we were sitting there, a call came from microbiology. What do you think was the positive specimen? Okay, there is a vote for this. Who would say, quickly. Okay, those who said CSF are right. But now, for the prize, you have to say what was positive in this case. Listeria. TB. TB. Enterovirus. No prize. Now this makes the case even more difficult now. How many believe that this will explain this presentation?
West Nile virus in the copper system can present as such. And this is one of the unusual presentations we see on West Nile virus. I'm not sure if we have a community cases of viral. I would vote first for West Nile virus if this is a virus. Yeah, but the glucose is low and the protein is very high, which is unusual for usual viruses. But West Nile virus has been shown with like multiple unusual presentations. TB is the other potential, from my side.
You all have IDs, and mashallah, I know there's a lot of people here sitting who are very outstanding IDs. when you get such a result, you always face it and you say, will this explain this? Yes or no? And how many of us, so the patient, and who, there are two parts of the area, طبعا هي سبب. The second part, the whole part of region.
With 9 virus that was reported to show acute classic paralysis, which can affect either one limb or multiple limbs.
Yes, Mustafa, but again, when I'm talking about, you are saying that it's not the varicella, it is the West Nile.
No, I'm not saying, but I'm not saying this is very unusual for the varicella zoster virus. This is very
It's reported in the literature that it is associated with a stroke-like picture. Very similar. So a case report.
Yes. So, varicella meningoencephalitis, it is a reactivation, 50% without rash. It causes arthritis, vasculopathy, myelitis, and cerebritis. So, unfortunately, he was kept on the meropenem and the acyclovir for the total duration of 3 weeks because we said he's improving on meropenem, but he had hysteria. He declined to have a repeat lumbar puncture, and he made a complete recovery in 4 weeks. So, it is a mystery to me. Does this explain what? I take it that the good thing about it, he made a full recovery. Either we are right or wrong, it doesn't matter.
Steroid given?
No. Doxycycline is not given.
After viral very good. Very uncommon. Especially after chronic paralysis has happened.
It's a real case. A real case.
Just, varicella reactivation because resides in the ganglion, you can have reactivation and then coming in the CSF without causing meningitis. So the presence of varicella in the CSF does not equal meningitis. So that's the problem with this. And my problem is this full recovery because viral meningitis, not meningitis, encephalitis is really, they come with sequelae. They cannot just go back to normal.
I have a comment on this, just because I have a room full of the same smartest people in IT. So I have exactly the same patient. The only difference in my patient is the young 35-year-old male, and he has a history of contact with a sick camel that has psoriasis-like lesions. The workup is all negative, including the meningitis encephalitis panel. My patient did get steroids 5 days, did get doxycycline, and still is not able to move any of his limbs. So he is not improving. So again, I have CSF. If anyone has ideas for send out tests, I'm happy to send out. فحبيت أفتح الفلور because of all the expertise in the room, and also people have more interaction with camels.
An active patient now.
Yes, and again, the camel history. I think we went down the MERS-CoV route, which was negative on 2 testing, and he did have a history of COVID in one of his hospitalizations. So again, opening the floor for any ideas, I'm happy to use them to take them to the bedside.
Next generation sequencing would be the answer in many of these cases if we don't have a good answer, because I think the differential diagnosis would be very wide. And if you have it available, I think that would be the best thing to do.
The last 10 tests we've sent have been negative, so we have never got back a good positive result from our center, or wherever we sent it to. Yes. Yes. Varicella negative, yes.
See, actually, in this case, to be honest, on totally recovered, I cannot say, because even the CSF was too much for varicella. So there is a lot of things here, but I am bringing it because this is the reality, this is happening. And for the people who are looking at it, especially the young trainees, actually, I thought that there will be more young doctors and trainees sitting here, that they have to know that they have to put everything together. That you should not take it that this is it. Maybe we missed something. Maybe he did have a form of a bacterial infection, which caused all these abnormalities, and he's recovered. In the last case, please keep your eyes open. Yes. 57-year-old male, long-standing SLE. He came with bilateral painful hand swelling. This is the pain and the hand he came with. But I will show you a picture. This is his hand before his presentation. Okay? So this is the door just for, because كيف نقصد في المدرس عندك اختراع Is it nice in the moment already? This is the era of the telephones, of the iPhone. It is easy. In the past, if you want the photo like this, you put the request, send it to the audio, send you a, no. عندك مانع؟ No, just take.
It's usually a selfie, but wait, small again.
Okay. So he has got this progressive for 2 months associated with erythema. He has no history of trauma. So what did they do, the rheumatologist? The rheumatologist, they felt that this is cellulitis, and then 4 months later, it recurred. They said that give him antibiotics and steroids. This is all the rheumatologists. We were not involved. 1 month prior to his presentation, he noticed a discharging abscess in the right side. Okay, he went to a local hospital. They gave him Ceproxim, no improvement. This is his past history. He has got lupus. He had non-Hodgkin lymphoma. He has got lymphoma. He had salmonella abscess. He had complete occlusion of his right brachial artery. And remember that. And his chronic kidney disease. He had got coronary artery disease. He's hypertensive, diabetic, and hyperlipidemic. He's a very nice man, very intelligent. He has got 2 sons who are doctors. So, recurrent, painful, I will just go. What is the differential? This is the rheumatological differential, isn't it? Inflammatory, infectious, complete region pain syndrome, because they thought because of this vascular issue, and then paraneoplastic syndrome. This is his PET scan, and you can see where is the abnormalities. It is mainly in the soft tissues. And this is the sum. And the sum mixed inflammation, he had a biopsy, acute and chronic osteo, numerous bacterial colonies, especially stained for fungi, were negative. He was treated with anti-Pseudomonas and anti-staph. So this was the impression. Again, this is his hand. You can look at it. This is actually the sum, which you saw that there is the necrotic tissue. Look at his hands very well. Okay? And this is his skin. Blood culture is negative. Now, synovial tissue showed mixed inflammatory cells, including lymphocyte and plasma cells. And the granuloma was seen in the synovial.
And the exposures?
It's work and exposure.
Exposures.
It's, no, exposure to what?
Fish
Actually, I don't know Mustafa. After that, he went to البحر الميت. حاولت صرت لما راح البحر الميت. جاء ذا راجع بأشياء ما غريبة. المهم, he has got a granuloma. Okay? So he has got poor form granuloma. So, what is the most likely cause of the granuloma? There is NTM, mycobacteria, Brucella, nocardia, fungal, or non-infectious. So, you want to vote? You have to scan it. How many minutes left? 1? Okay. Because the time saved. Because, yes.
With no card.
No card. Okay. Look at this very well. Now, who will pick this? He will get the prize. It is Leishmania. He has got Leishmania. This is one of them. I have never seen a case like this. He has got Leishmania affecting the color. Now we just stop here.